Baik, para dokter dan juga tamu undangan sekalian, kita akan kembali sama-sama memasuki sesi yang kedua, di mana untuk sesi yang kedua ini adalah dengan judul Taking the Next Steps in Refractive Surgery. Dan sama seperti pada sesi sebelumnya ya, selain presentasi dari para narasumber, kita juga akan sama-sama melihat contoh-contoh kasus yang menarik dari para pembicara. Dan tanpa berpanjang kata lagi, kembali saya undang kepada moderator kita, ada Dr. Ria Sandi Deneska, spesialis mata konsultan, yang nanti akan kembali didampingi oleh panelis di sesi diskusi. Kepada Dr. Ria Sandi Deneska, spesialis mata konsultan, waktu dan tempat saya persilahkan.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Dengan saya lagi, kali ini kita lanjutkan dengan sesi 2 dengan 3 pembicara, 1 lecture dan 2 presentasi kasus. Kepada para pembicara kami harap untuk naik ke panggung. Please to the speaker to join me at the stage, Dr. Gaid Kundu and Dr. Soraya Feranti. Also Dr. Brendan Cronin. The first speaker would be Dr. Gaid Kundu will present the topic with the title Using Biomechanics to Take My Refractive Surgery to the Next Level. Okay. Please, Dr. Kundu, time is yours.
The second one, yeah. So, back again. So, we'll be speaking on corneal biomechanics, a little more in details about screening indices, your conundrums pre-operatively, and also how you can use, somebody asked about biomechanics post-operatively. So, we'll be speaking on that as well. So, like I said, you're, of course, on a regular day, you see your topography, it's normal, you see your biomechanics normal. Well, it's not a problem. And I can do whether a flap or whether a lenticule-based procedure. And of course, the other end of it, you have keratoconus, like Dr. Brendan said, your CBI will anyway be deranged. You don't need to really, it's not that your CBI is going to be borderline in the picture which you see on the right. So you have two extremes, everything normal, everything abnormal. I think that is something which we want and we love. We know what to do in such scenarios. But it's in scenarios which fall in between is where, optimizing your practice is very, very important in that scenario. Where, how do you approach cases which fall in between, where you're looking at your bad D being normal, your CBI somewhere in the middle, what do we do, what procedure do we do? And I will try to kind of simplify in terms of what we are, planning to, or what kind of nomogram we follow. So of course, it's open for discussion. So biomechanics for evaluation ectasia is something which is not new. It's important to understand that inherent biomechanical strength is as a consequence of the arrangement of collagen. Currently, no devices image collagen. We have a prototype known as polarization sensitive OCT, which looks at collagen. But what I'm trying to infer or derive is that the biomechanical parameters could be a surrogate marker for many things which is happening underneath. Whether it is changes in the collagen, changes in the inflammatory profiling, and I will be showing you as to how, just by using biomechanics, that could be a surrogate marker for a lot of other things. So I don't want to go into, I think he's spoken about it. You have a real-time, a high-resolution imaging. So Corvis stands for corneal visualization, ST is Scheimpflug. You're using a high-resolution, ultra-high speed camera. You put a puff of air, your real-time imaging, the cornea deforming, going to the point of maximal concavity, and then coming back again. So that is what biomechanics is. That is what is giving us, what the inherent corneal strength is in the form of the various indices, which I will be speaking upon. So, among the parameters which I would want to speak about is something known as CBI. Okay. Now, we of course know the fact that in keratoconus, there is inherent weakening. Some people asked about the role of this. You don't need to do separately a biomechanics for cases where there is an advanced keratoconus. But in earlier cases, looking at the first applanation and the second applanation, which kind of gives you the corneal hysteresis, could play an important role in cases which fall in between. In terms of patients which fall in between, there is a wider scattering of these biomechanical parameters, and it is therefore prudent in patients which fall in between where you could do a biomechanical imaging. So again, these are some images of your recovery. You're of course doing the first applanation, goes to the point of maximal concavity, and in weaker corneas takes a longer time to come back. And based on this principle is what several of these parameters are derived on. So what it also gives you is, Dr. Brendan spoke about, is TBI, where you're using tomographical data, combining it with biomechanical data and giving an index. So CBI is purely biomechanical. TBI is a combination of biomechanical and tomographical data, and integrating tomography and biomechanics will increase sensitivity of your ectasia detection. So a lot of work done by Renato Ambrosio on how they have used biomechanics in early detection of ectasia, enhancing ectasia detection using AI. That is something which has already been published on. So some important parameters. There is a cutoff. It is 0.25 to 0.5 is somewhere in between. 0.5 above is abnormal. But there are individual indices which is also important. Something known as the deformation amplitude ratio at 1 and 2 millimeters. Something known as the Ambrosio's relational thickness, which is basically a ratio between the thinnest point and the pachymetric progression, and stiffness parameter, which is SPA1. So though we get like bad D, there is a cutoff, 2.6, it's abnormal. CBI, there is a cutoff, but you need to understand majority of them are influenced by OP. SPA1 is a parameter, which is the stiffness parameter at the first applanation. If you see in this here, okay, where it is thought of to be independent of the intraocular pressure. Understanding that each one of these is what finally determines the CBI is also important. I spoke about bad D, those individual parameters which affects the final bad D. The same thing is with biomechanics as well. But having said that, we finally want cutoffs. CBI is what we generally fall on with. TBI is also, an important cutoff. What we normally see is anything which is between 0.25, 0.5 abnormal, above 0.25, certain that there is an abnormality. As we go towards the end of the spectrum, 0.6, 0.7, it's certainly a risky cornea. Now, corneal biomechanics, what Corvus does is imaging only the central part. You're looking at a puff of air which is applanating only the central cornea. But what we've also done with the Corvus is the concept of regional biomechanics. And what we've found is that in certain changes, in not only the central cornea, even when the patient looks up or looks down, so we've kind of tailor-made Corvus into looking at multiple target points, not only in the central cornea. So this is a concept of focal biomechanical change versus regional biomechanical change, and this is something which the Corvus also can help us in. So to kind of simplify, you of course are using biomechanics to look at how weak the cornea is, deciding on surgeries, how to customize. You spoke about customized treatments, customized cross-linkings. When do we treat? Is it actually progression? And can we look at how it helps us in post-operative or post-LASIK ectasia detection? And that is also something which is important in the scenarios. So there is a knowledge gap, but how do we actually make this more understandable to clinicians? I think that is only confusion is that I know tomography, I might not know enough about tomography or any imaging device. How do I integrate biomechanics into my practice, and what are the situations as to where we can actually, use biomechanics and help us answer questions. Finally, that's what it's important, right? We need to know what do we do in what scenarios. So our approach is to kind of divide it into, certain segments to kind of simplify it. You of course have a chunk of patients where there's normal topography, normal biomechanics, but you also have a chunk of patients where topography, bad D are normal, biomechanics, CBI and TBI are borderline. What do we do in certain scenarios? Group 3 is where your topography, bad D is borderline, but your biomechanics is normal. So you see your TBI is being somewhere in between, but your biomechanics is normal. What do we do in such scenarios? And your group 4 is of course easy, where everything is abnormal. So group 1 and group 4, as I spoke about the ends of the spectrum. The ones in between are the ones which are finally confusing to us. I basically am trying to integrate. So we do something known as collagen imaging. If you see the images in the blue, this is an ultra-structural imaging. This is a device developed, and it will be taken forward, of course, where we are actually looking at the collagen strength. Okay. Finally, whether a cornea is strong or weak is based on the collagen. I'm not trying to drive home the message that you need to get a device which looks at the collagen. What I'm trying to tell you is we have imaged collagen in varying scenarios, and what we have found is biomechanical parameters such as CBI correlates very well with this, the collagen strength, and therefore it is an indirect surrogate marker. So for people who are telling me that, sometimes CBI can also go wrong, well, that possibility is quite less, because what we have shown it in our research and experiments is that it correlates very well with your collagen itself. So you don't have a collagen imaging, no problem. If you have a biomechanics, that kind of correlates very well in, the distribution of collagen fibers. So how do we apply this to our clinics? There's no problem on group 1. You're of course, you do a clinical evaluation, you look at everything else. I'm excluding the fact that you already know about the part to be corrected, look at the RSB, calculate that corrections apart. So you can do a flap or a lenticule-based procedure in such scenarios. Group 2, where, you see your bad D normal, but your CBI and TBI somewhere in the borderline. And this is where it's important to recheck parameters specifically in CBI. There are certain parameters where these are independent of the IOP, and it would be prudent to look at that. So I know he hates about glaucoma, but I will be speaking a little bit about IOP. We kind of have developed an algorithm as to where we look at the biomechanically corrected IOP, and if we find that it is normal, we then go into looking at the specific stiffness parameter, which is SPA1. And what we have seen, and we've correlated that with our work and publications, is SPA1 being above 100 is a very good cutoff. So CBI is somewhere in the borderline, but you again look specifically at something known as SPA1. That is something which tends to be even more sensitive, and that could help you in arriving at a decision as to what you want to do. In cases where the SPA1 is reduced and the CBI is borderline, it would be prudent not to proceed with a flap or a lenticule. You could do an extra procedure. In cases where you see the CBI borderline, but your SPA1 is good, it could still mean that the cornea is, has a good mechanical strength. Always look at other parameters such as IOP, I'm sorry, Dr. Brendan, and then proceed with interpreting this, and that is something which is important. So group 3 is where you have borderline, tomographical changes, but your CBI is normal. And I think I spoke about this in the case examples. Now you're able to correlate, is where some changes in the ocular surface can throw up as changes on the curvature maps, can also drive bad D to be somewhere in the middle. But CBA is telling me a truer picture, it's normal. So if you don't have access to, a pentacam, you don't need a pentacam OCT, you can use any AS OCT, but a pentacam OCT would kind of help you because it will also give you an epithelial mapping. In such scenarios where you see the bad D being abnormal or borderline, but your CBA is normal, look at the axial or the sagittal curvature map, and invariably these are changes in the epithelium which is masking changes on the curvature maps. it would be prudent to, rule out ocular surface diseases, dry eye, manage that, and then reassess. And that is something which is important, and then proceed. The fourth one, well, it's easy. Voila, many of these patients sometimes are not, fit for laser refractive surgery in the cornea. The role of it's beyond the scope today, but the role of phakic implantations have a very good role. So your group 1, you know what to do. It's normal everywhere. Your group 4, also you know that everything is abnormal. Your group 3, look at ocular surface issues. Your group 2, make sure that you look at other parameters and stiffness parameters, something known as SPA1. So I hope I kind of simplified it. Your 1 and 4 is easy. Your 2 and 3, well, it is subjective. We have tried to build an algorithm into that. Okay. So now what we also did is we kind of linked biomechanics to changes in the stromal maps. Okay. This is another device. So this is, you see, this is a tomography. You see there's some amount of changes which you see in the biomechanics, but overall, if you see, there's not too much of a change in the in the 4 maps in terms of the curvature, but you do see certain changes in the posterior elevation. Okay, now notice the CBI is highly deranged. Okay, topography, well, is somewhere on the borderline. You can see some amount of posterior elevation, but you see poor gonal biomechanics. And so what we tried to do is there are certain tools which help us in looking at something known as stromal mapping. And if you see the stromal elevation, there is some stromal elevation which is telling me that there is some amount of weakening or an early ectasia. And what it proves is that the CBI correlated very well with the stromal elevation. So the second surrogate marker, the first one I spoke about CBI correlating very well with collagen changes. The second thing which I spoke about is now CBI correlating with stromal elevation as well. So you need not have a stromal mapping device, but what I'm trying to say is CBI does that job for you because we have, kind of looked at correlation. So the second surrogate marker of stromal elevation is again the CBI, and that is something which is important to remember. This is another case, you see not too much of changes in the topography, but if you see biomechanics deranged, and that correlates well with the stromal elevation. So this is the normal checkered pattern which we see on the collagen fibrils, and this is the same patients where you see the there's a complete loss or a dysregulation of the arrangement of the collagen fibers. Like I said, CBI is correlating well with even the collagen changes. So the inference is your poor corneal biomechanics invariably is telling me about collagen fibers being sparse or disorganized. These are biomechanically weak cornea, so CBI generally doesn't go wrong. And in such cases, it's always advisable to avoid either a flap or a lenticule, or you can do a lenticule with an extra procedure is what we follow at our center. The case scenario 2, you see topography and biomechanics, you see a focal change on, if you see the standard BFS and the enhanced BFS difference. We went ahead in such scenarios, did the phase retardation. This is the collagen imaging. And what we found is that even with terms of how you could be misled in terms of posterior elevation, even in such scenarios, the collagen imaging did correlate very well with the CBI. So that is something which is important in various case examples. So this is a simplification of the whatever I spoke about. You have given it a name. It is about to be published. It's the Bate nomogram. Okay, I think it's. Okay, so always segregate, looking at tomography, looking at biomechanics, and then deciding on what surgery is feasible. And that is something which is important in customizing. So group 2 and 3, you might have rejected those patients, but in fact, we are optimizing and increasing the patients who are actually undergoing refractive surgery. Because group 1, you anyway will operate. Group 4, anyway you will not operate. It's group 2 and 3, where majority of you might not operate, and where we are actually converting those patients back into the fold. So, refractive surgery is an art, is a science, and is also a balance between your measurements and the outcomes. But invariably, many of the times, outcomes can be unpredictable. Though, you see you've got the correct device, you've got the correct measurements, but what happens is you really don't know about outcomes. And that's where many of these imaging modalities has made our lives easier. We are speaking about CBI being done post refractive surgery, and that is also a very useful thing to do, where we are actually looking at using biomechanics for questions to be answered post refractive surgery. Whether this cornea will get weaker as we go ahead after the surgery. Will there be an ectasia? We really don't know. And does an extra procedure help at the outset itself? And is it making an actual difference after the surgery? So till now I was speaking about biomechanics as a screening tool. I already have decided that I'm going to operate on the patient. I have done the surgery. But after the surgery, even if everything was normal, we sometimes still see ectasias happening. What are those answers? And biomechanics has a very, very important role in those scenarios is what I'm trying to highlight in this. So, I will be skipping some aspects of this. Yeah. So you get an option of ticking the post laser vision correction on the CBI. Okay. One is of course untreated. The second one is the post laser vision correction mode, which kind of helps us in looking at biomechanical changes, which is post refractive surgery. So remember to select the post LVC option when you're looking at the biomechanics. So you can also select the surgery performed, and accordingly they have a normative database which post LVC they kind of do a match, and that can kind of give you a fair idea as to the biomechanical strength after the surgery. And not only a one-time evaluation, you can of course, as the patients come back for follow-up, do a serial follow-up, and that can help you in detecting and looking at ectasia and evolution. So it helps us in distinguishing stable post laser vision correction corneas which are at risk from ectasia, which are not at risk for ectasia. It has a very high sensitivity and specificity, but it's some aspects of it are dependent on IOP. Can we go a step or a notch ahead and looking at other parameters which are not dependent on IOP? And that's where the concept of a stress strain index. This is again another index which you see on the corpus, where you look at the regional variation of the corneal stiffness across the corneal surface. And it's important that this is independent of the thickness and the IOP. So IOP has less role, again, sorry, Dr. Brendan, in this parameter, which is the SSI. And he spoke about, how you can actually look at it post a surgery. It gives you whether it's the cornea is getting stiffer, whether it's getting weaker, or there's no significant change. So you're looking at CBI, LVC, which is post laser vision correction. You're also looking at SSI, which is an important tool in this scenario. So again, we have kind of done studies on looking at how sensitive and specific it is. Very sensitive, very specific. We are still in the process of looking at long-term studies. CBI LVC has a lot of long-term studies, but role of SSI in post-operative quantitative measurement of ectasia detection, long-term outcomes is something which we are still working on, and it should be out soon. Now, your post-operative, imaging modalities invariably would have poor repeatability immediately done after the surgery. That is something which you need to do and remember. Epithelial changes and stromal changes or epithelial remodeling in the immediate post-operative period can have a role in how we actually lack the complete picture. And that is where, what all can we actually integrate into our armamentarium. So I'm not digressing, I'm speaking about biomechanics itself. What I spoke initially was about how CBI correlated well with collagen, CBI correlated well with stromal mapping, and how CBI, LVC, and SSI are very sensitive and specific markers for post-biomechanics, ectasia, detection and early sensitivity. But there are certain other imaging modalities which we have also started to look at. I spoke about collagen imaging, where we are actually using a non-invasive way of detecting collagen, the collagen arrangement. So what we did is integrate all of this. I spoke about how weak the cornea gets post-operatively. If you see SMILE and LASIK, every time people ask about whether which procedure is better, and are there any biomechanical changes. So this is a paper done by my colleagues. I was a fellow back then, done by Dr. Rohit and Dr. Pooja, on using biomechanical parameters for LASIK, the flap and the smile cap. Of course, there was ethical committee clearance. We did a pre-operative biomechanics. We did a flap cut, flap lift, and a cap cut. We again did biomechanics after that, then took them back, completed the surgery. Then we did a post-operative 1 week biomechanical change and a post-operative 1 month. So what is interesting is that a LASIK flap cut induces a lot more of biomechanical weakening than a smile lenticule cut, no doubt. But what is important is that that is in the immediate post-operative period, and by 3 months to 6 months, invariably that kind of negates itself. So there is no statistically significant difference if you're looking at LASIK and smile based on existing safety criteria for long-term outcomes. So we kind of used biomechanics in trying to look at your immediate post-operative outcomes as well as your 3 to 6 month post-operative outcomes. And we found that though immediately there was a change, it wasn't the case in the long-term outcome. So again, we kind of correlated this with our polarization sensitive OCT. You see immediately after your LASIK, your flap cut, you do see an alteration in the collagen and the phase retardation is what we call it. This is just something for improving your understanding, but this was anyway something which we correlated with our biomechanical parameters, including the CBI. Now, will there be ectasia post-operatively is again something which we really don't know. You get cases where there is a focal steepening. Is this an ectasia and evolution is always the question. And that is where important to do serial measurements, especially of, I spoke about the CBI, LVC, and the SSI. And what we do in addition to that is look at collagen, look at the arrangement of collagen, and also we've had, I've had an opportunity to work with the Brilliant microscopy. So progression of the indices, especially when you're doing a serial follow-up of these patients who have undergone a laser vision correction, it's important that any change sometimes can warrant an intervention, and these patients have to be on a close watch. Collagen assessment, which I spoke, correlated very well with the serial measurement, and what we have shown is even on follow-ups, if there is a change in the parameters of stiffness on the corvus, that correlated very well with the changes which you see on the collagen. And not only that, it also correlated very well with changes which we see on Brilliant microscopy. So what I spoke about is CBI is a surrogate marker for a lot of things. CBI is a surrogate marker for your collagen orientation. CBI is a surrogate marker for stromal mapping. CBI is a surrogate marker in even terms of optical spectroscopy, which you get through Brilliant microscopy. So you might not have the previous three, but as long as you have the corvus, it kind of gives you a very, very clean, good picture. The last aspect is something about extra procedures. Some people are asking about LASIK extra. We don't do a LASIK extra in cross-linkings, but in patients, I spoke about group 2 and group 3, where there is some amount of abnormality, especially in group 2, where these are the patients who fall somewhere in between. Does an extra procedure help? This is of course open to discussion. Patients where we feel have borderline tomography, borderline CBI, you see the SP1 also being a little on the lower side. In our practice at least, we tend to do an adjunct therapy in addition to a lenticule, a smile or a silk. We can do an extra procedure, and this is something which has been proven. A lot of groups have worked on long-term outcomes of extra procedures post-refractive surgery. So how can biomechanics help us in looking at that aspect as well? That is where understanding the fact that a poor corneal biomechanics invariably is risky to undergo a surgery which is a regular flap or a regular cap or a lenticule. An adjunct procedure such as an extra could help in kind of strengthening the cornea in the immediate and therefore preventing post-operative ectasias. So now what we also did in the last aspect is that once these patients have undergone surgery, I spoke about changes in the biomechanics. There is also changes which is happening at the level of the keratocytes. And using confocal microscopy, what we found is that an extra did induce some amount of subclinical scarring. That's what it basically does. And therefore, the possibility of it undergoing ectasia at a later date versus just a regular smile for the cases are something which is less. So if you see the collagen assessment, this is pre-op and post-op, you see the increased arrangement of the collagen in the picture in the right lower, where you see post-smile extra, it's actually undergone more strengthening, and therefore, which is just trying to prove that extra procedures as an adjunct should be actively considered where you have these conundrums where tomography does not fit the bit, or you have a difference between tomography and your biomechanics. So especially in group 2, group 3 is more of ocular surface issues. Group 2, extra does form an important aspect of your treatment modalities and what you advise. So what are we trying to say is that you have actually increased the number of surgeries you're doing. Why is that so? Is because patients who would have otherwise rejected can still undergo surgeries. Of course, the aspects of looking at the power to be corrected in RSB, I'm understanding that you already know about that. In addition to that, if they're fit for a lenticule procedure, but they're somehow in between in group 2, extra works very well, and that is something which you need to remember in this case. Cross-linking effect at the biomechanical level, we've also done some work on normal wound healing and how it correlates well with biomechanical changes in cases where there is excessive myofibroblast activation in an aberrant wound healing. I don't want to go into too much details on this. In some cases you see patients coming up with this scar, and what we've shown at the molecular level is excessive activation of these keratocytes leading to myofibroblasts, leading to scarring. And what we've correlated that with is also with the biomechanics. So again, I'm summarizing biomechanics. I told you about biomechanics correlating with collagen, correlating with stromal mapping, correlating with optical spectroscopy of Brillouin, and also biomechanics correlating with molecular changes which is happening. So we have shown that your biomechanical indices is a very good surrogate marker, and this is something which we also do in our clinics. We kind of measure tear inflammatory profiling of all patients, especially patients who undergo surgery, post-surgery adverse outcomes, what exactly is happening on the corneal surface, and that is where we kind of look at specific cytokine profiling. Now, in smile cases, we don't throw the lenticule. Okay, this is something Dr. Rohit told us 10, 15 years back. We have a repository as to where we, preserve those lenticules into a biorepository, and we have published cases of post-smile ectasias. And many years later, when they come to us back with ectasias, people say, I've not seen ectasias. No, there are ectasias. When they come back is when we actually take out the lenticule of that patient, which was preserved, and look at inflammatory profiling. You don't have to have an access to it, but what I'm trying to come to is that biomechanics correlates with inflammatory profiling markers as well. Okay, so this is a case where a normal preoperative eye went in for ectasia many years later, and what we found in the gene expression analysis of the lenticule is a reduced lysyl oxidase level. Lysyl oxidase is the one which helps in your turnover of collagen, and that is the reason as to why, in spite of a seemingly normal tomography, patient did not have Corvus. This is, maybe 10, 14 years back. That center did not have Corvus, one of our centers. So therefore, what we moved ahead and looked at is that these are the patients where inflammatory profiling can also predict post-operative outcomes. That is, of course, a different talk, not related to today's session. But what we kind of looked at is that many of these tear profiling markers correlated well with biomechanical change. So maybe if we had done a preoperative biomechanics back then, that patient might not have just undergone a lenticule. It might have fallen in group 2, undergone a smile with an extra, that might have avoided the ectasia. I hope I'm clear on that. Okay. So again, before I end, you see biomechanics is not a single arbitrary value. It's just not 0.25, 0.5. I spoke about so many other things. That 0.25 is also telling me about the collagen. That 0.25 is also telling me about the stromal elevation. That 0.25 is also telling me about the, the inherent properties of the cornea through a brilliant microscopy. And that CBI 0.25 is also correlating with changes in the inflammatory profiling, which could play a role in future ectasia development. So I hope I'm trying to put this all back, that it's just not a single value. We have correlated this with a lot of other parameters as well. So remember, you have CBI, you in fact have a lot of the other tools as well. You also have PSOCT indirectly. You also have a tear inflammatory profiling indirectly. You also have a confocal indirectly. So indication of an early stage can guide appropriate intervention. Okay? Somebody asked, do I need to invest in a corvus at the outset? This is the reason why you need to invest at a corvus at the outset. It is to optimize your practice, and early detection of anything, an ectasia, an evolution, or a post-operative ectasia can in a long way alter the outcomes as to how you treat these patients. And that is what is something which is important in this scenario. Before I end, Dr. Brendan will be knowing about that. We have built something known as AccuSymX. AccuSymX is a predictive modeling where we have reconstructed the cornea, okay? And it's something like crash testing of your cars, They do of course crash test the cars, but they also sometimes, use certain data points and rebuild and then make the car go through certain parameters, crash, burn, fires, etc. So what this is we have reconstructed the cornea, done something known as an FEM model, and these are the patients which undergo LASIK, SMILE, and PRK, not actually, through an FEM model, and which one of these patients have the highest probability of developing ectasia. So this is an AI algorithm where we have used our database. If this is the eye, this is the reconstructed eye, and this patient undergoes SMILE LASIK, what is the predicted post-operative stiffness change? And that is what this software does. So this is something which has undergone multiple iterations. This is something which I think Dr. Brendan's also worked with. We're also, validating this at a larger cohort. And an important aspect of what we import is, of course, biomechanics, and that forms an important chunk of how we actually run this software. And it kind of gives you a report as to which of the surgeries would be the safest. And finally, that's what we want. We want our ectasia risk, scores to be at a level where we are aware, okay, if I do this surgery, this is the safest bet. And the only thing people ask me is, why don't I just do a PRK? You can't do a PRK in all cases. Patients who deservingly need, can undergo a SMILE on LASIK, do deserve to undergo a SMILE or LASIK, and that is where softwares like this, that is where biomechanical parameters which I spoke about play an important role in these cases. So, okay, so this is something we have validated and published. So remember, it's not an isolated entity. You should use that in conjunction with tomography. You need a holistic approach. Segregate your patients, build nomograms. I spoke about, we're dividing into 4 groups, and that kind of helps you in optimizing your practice. So yeah, thank you.
Thank you, Dr. Kundu, for your very interesting presentation. Now we come to the second presenter, Dr. Soraya Ferranti. Please, Dr. Soraya.
Richard, on the OCT, I'll do it after she presents. Yeah, okay. I have some data on Pentacam OCT as well. So for people, I know this is on AXL wave, but once she's done, I can maybe show you some aspects of how OCT integration with Pentacam has played a role in our practice. I'll do that after her talk, yeah.
Thank you. All right.
Thank you, Doctor.
Untuk saya butuh bantuan dari operator ya. Baik. Terima kasih. Assalamualaikum warahmatullahi wabarakatuh. Selamat siang. Good afternoon, ladies and gentlemen. Saya Zoraya, dan pada hari ini senang sekali kesempatan untuk berbagi sedikit mengenai aplikasi langsung pada keseharian praktis kita sehari-hari dari segi biomechanical aspect. Boleh, next. Sebagai sedikit background aja bahwa biomechanical cornea itu berperan sangat penting tidak hanya dalam hal menentukan diagnosis derajat keparahan tapi juga untuk menentukan beberapa aspek yang ingin kita approach atau pendekatan-pendekatan khusus pada saat operasi. Kekakuan dari kornea kita tahu ini sangat dipengaruhi oleh extracellular matrix, microstructure, komponen dan juga kolagen fibril dan juga proteoglikan dan bagaimana tisu tersebut terhidrasi dan dehidrasi. Next. Baik, seperti kita tahu bahwa kornea itu adalah jaringan yang memiliki banyak beban, terutamanya dari eyelid atau kelopak mata, kemudian tear film, intraocular pressure, external forces seperti kebiasaan menguncak mata, kemudian penggunaan kontak lens dan juga surgical intervention seperti blepharoplasty yang sometimes too tight, it can change the corneal curvature. Next. Lalu pentingnya apa kita mengetahui biomechanical cornea dalam kehidupan praktis sehari-hari? Next. Sebagai latar belakang juga bahwa dulu kita selalu menggunakan pentagram, kemudian pachymetry, kemudian topografi ini selalu dijadikan sebagai lini pertama. Namun penelitian-penelitian lanjutan mengatakan bahwa ternyata tidak cukup saja bahwa kita bicara dari satu parameter. Ternyata memang seperti yang tadi Dr. Gori katakan bahwa keputusan untuk melakukan tindakan lasik ataupun smile pro ataupun other refractive surgeries itu sangat merupakan kumpulan dari beberapa pemeriksaan yang sudah kita lakukan sebelumnya. Berapa tissue alter, persentase tissue alter yang kita akan sisakan, kemudian bagaimana Randleman scores-nya, kemudian tentu saja semua itu bermanfaat, namun ternyata tidak cukup untuk dapat menentukan apakah pasien ini akan develop ectasia in the future or not. Jadi ternyata banyak temuan-temuan ektasia yang terjadi pada topografi yang dalam batas normal. Next. Kemudian tidak hanya kita dapat memprediksi apakah kelainan tersebut secara keratoektasia akan terjadi, tapi kita juga bisa menentukan apakah kira-kira pasien ini akan banyak mendevelop aberrations after surgery. Banyak korelasi antara total order aberrations, lower order aberrations meningkat pada pasien-pasien myopia dengan biomechanical yang strong atau kuat dan tebal. Next. Next lagi. Nah, ini case pertama. Kita bisa lihat di sini, ini bukan brainer, kasus yang mudah saja karena jelas bad D-nya sudah mengarah pada angka 5. Next lagi. Kemudian kita bisa lihat bahwa ada asymmetrical 8 configuration di situ, di bawah ada inferior stiffening. Boleh next. Kemudian kita bisa lihat bahwa angka-angka dari semua parameter Berlin Ambasio display-nya juga menunjukkan kelainan. Kemudian berikutnya kita bisa lihat bahwa ini adalah pasien keratokonus. Pasien ini datang setelah melakukan pemeriksaan hal yang sama dilakukan 1 tahun yang lalu di Qatar. Boleh next? Next lagi. Yap. So ini adalah pemeriksaan yang dilakukan di Qatar tahun 2024 dan menunjukkan kurang lebih K1 K2 yang relatifly sama. Tapi seperti tadi Dr. Brandon dan Dr. Kari katakan, apakah cukup kita melihat dari segi K1 K2 lagi, apalagi Kmax katanya sudah outdated. Kita boleh next lagi. Next. Yap. Ternyata dari hasil biomechanical corneanya memang menunjukkan CBI dan TBI-nya memang menunjukkan angka yang relatifly besar. Sehingga next lagi pasien ini memiliki unstable cornea, kemudian usianya 40 tahun dan juga memiliki frequent eye rubbing due to allergies. Visus terbaiknya adalah 20/30. Oleh karena itu pasien ini kita rencanakan untuk next slide. Kita observation dulu karena usianya sudah 40 tahun, tapi juga kita masukkan allergic medications, larangan untuk rubbing the eye. Nanti akan kita evaluasi lagi plus minus scleral lens untuk meningkatkan visualnya dan juga plus minus cross linking. Nanti kita akan evaluasi lagi. Next. Corneal biomechanical itu juga sangat dekat dengan glaucoma practice seperti yang tadi sudah sempat dibicarakan. Kita langsung aja next lagi. Untuk yang case kedua, laki-laki 19 tahun datang untuk screening laser vision correction. Tentu saja biasanya kalau usia semuda ini datang dengan tujuan untuk mendaftar ke sebuah akademi. Dari epithelial mapping kita bisa lihat bahwa ada yang mencurigakan di bagian inferior mata kiri, mata kanan juga funny looking epithelial thickness. Next. Next lagi. Dari segi format refractive kita biasa ngelihat K1, K2 dan berbagai parameter. Next lagi. Ada yang mulai elevation di back, Tapi apakah ini bermakna ataupun tidak? Kita next lagi. Oke. Angka bad D-nya adalah 1,87 yang mana sometimes bisa berarti, sometimes juga angka-angka border gini tuh bisa juga tidak berarti. Oleh karena itu kita konfirmasi dengan pemeriksaan selanjutnya. Next. Oke. Kita lihat juga mata yang sebelahnya, mata kiri, obviously ada skewed, ada thinning dari back elevation. Kemudian kita lihat bahwa angkanya sudah mencapai 7,39 dan juga ini menyatakan bahwa kelihatannya mata yang kanan juga akan menuju ke arah keratokonus. Oleh karena itu, next, kita lihat dari segi pemeriksaan biomechanical-nya, total biomechanical index-nya itu juga 0,61. So that's sudah above dari angka border yang tadi sudah ditentukan. Next lagi. Posterior segmen dalam batas normal. Berhubung pasien adalah pasien muda dengan kornea yang lemah, kemudian dengan kesulitan dalam melihat pada saat kegelapan, tidak disertai dengan kelainan-kelainan lain, tidak ada alergi, tidak ada kebiasaan rubbing eyes, maka pasien ini sebetulnya masuk ke dalam fase observasi, namun direncanakan untuk jika memungkinkan transepithelial corneal cross-linking plus scleral lens. Next. Case yang ketiga, laki-laki 26 tahun. Next. Oke, dengan tampilan pentacam atau topografi yang relatively normal, boleh next. Terus next lagi, kita ngelihat nggak ada permasalahan. Kemudian selanjutnya, begitupun juga pada mata yang sebelah kiri, topografi menunjukkan dalam batas normal. Next. Terus next lagi. Oke, kita lihat biomechanical juga baik. Jadi kita cukup merasa nyaman untuk melakukan tindakan pada pasien tersebut. Namun karena karena ukuran refraksinya yang besar yaitu minus 1575 dengan silinder 3,5 pada mata kanan dan mata kiri, next. Minus 14,25 silinder 2,25 dengan BCVA pada saat pre-operatif adalah 0,6 dan 0,5. Oleh karena ini pasien ini kita rencanakan untuk tindakan ICL. Boleh next? Karena kita selain menentukan apakah tindakan tersebut baik atau tidak, salah satu parameternya adalah berapa persentase yang akan kita lakukan ablation, kemudian berapa sisa residual stromal yang akan kita sisakan dan juga persentase stromal bed thickness yang mana akan melebihi dari angka-angka yang sudah ditentukan. Next, oleh karena itu pasien tersebut dilakukan tindakan ICL dengan outcome mata kanan 1,0, mata kiri 1,0 dan kedua mata 1,25. Pasien kemudian di follow up rutin. Next. Oke, pasien tersebut dengan vaulting yang baik, mata kanan maupun mata kiri. Next lagi. Baik, slide selanjutnya. Next. Oke, case yang keempat, wanita 37 tahun, screening untuk LVC, tidak ada kelainan dengan regarding vision, pengguna kontak lens, dengan topografi dan tomografi yang within normal limit. Boleh next. Next lagi, kita bisa merasa cukup yakin. Next lagi, hasilnya juga dari biomechanical-nya bagus, baik mata kanan maupun mata kiri. Next lagi. Next. Iya, namun ternyata pada saat kita lakukan pemeriksaan funduskopi, kadang pasien suka menyimpan rahasia-rahasia di matanya dan ternyata kita dapatkan adanya bulging di area inferior temporal. Akhirnya kita konfirmasi dengan funduskopi, next kita temukan bahwa adanya massa di koroidal, sehingga pasien ini disuspek dengan koroidal hemangioma, choroidal melanoma, sehingga kita akan rujuk ke spesialis onkologis dan follow up berikutnya. Next. Berikutnya. Oke, ini case yang saya ambil yang menarik yang dilakukan oleh Yan Wang dan kawan-kawan, yang mana biomechanical juga mempengaruhi pembentukan OBL during smile. Inilah yang dimaksud bahwa tidak hanya untuk penegakan diagnosis saja dan juga untuk menentukan terapi, tapi juga kita bisa gunakan untuk approach pada saat melakukan lenticular surgeries. Sebagai contoh, pasien-pasien yang korneanya lebih dari 530, itu jika dilakukan laser setting dengan cap thickness yang cukup tipis, di atas 120, maka katanya itu dapat meningkatkan kemungkinan kejadian aberrations dan juga OBL during surgery. Boleh next? Jadi kita tahu bahwa selain itu, biomechanical cornea ini juga dipengaruhi oleh beberapa ethnic differences yang mana mempengaruhi ketebalan kornea, corneal curvature, BAD, anterior chamber depth, dan axial length. Oleh karena itu, dengan adanya new Corvis ini dia lebih mengoptimize pada Chinese population. Next. Ini bisa jadi bermanfaat untuk pasien-pasien kita dengan pasien-pasien yang beretnis Cina. Kemudian kita bisa sebagai background juga kita bisa mengetahui bahwa banyak sekali perubahan biomechanical changes yang terjadi sebelum morphology changes. Nah ini yang penting untuk dijadikan consideration sehingga itulah pentingnya kita mengetahui kondisi biomechanical pre-surgery. Next. Jadi tentu saja kita semua sebagai bedah refraktif ingin memberikan pasien dengan 20/20 dengan kualitas terbaik. Sama-sama mencapai 20/20 namun dengan kesulitan menyetir di malam hari, kemudian kesulitan untuk fokus pada jarak tertentu dan penerangan tertentu, tentu kita tidak ingin memberikan ini kepada pasien kita. Next. Seperti yang Dr. Dan Reinstein sering katakan bahwa refractive surgery adalah sebuah dedikasi. Dia sudah melakukan tahunan tindakan refractive surgery, namun sampai detik ini masih banyak temuan baru yang perlu ia pelajari lebih lanjut. Sehingga kita perlu mempersiapkan diri kita dengan pemeriksaan yang terbaik, sehingga kita bisa memberikan yang terbaik untuk pasien kita. Kita harus develop dari jadi dokter yang bagus menjadi dokter yang hebat. Sekian dari saya, terima kasih. Slide.
Terima kasih Dr. Soraya Ferenci. Now we come to the third speaker, Dr. Brendan Cronin, please. Time is yours.
Okay, thank you. Some great images in those slides, very professional PowerPoint presentation. So I just have 3 cases just to cover. It's meant to be a little bit interactive. It's hard with such a large audience, so you may have to do it in your mind. If we go to the first slide, please. Well, the first slide that isn't me. Yeah. Next. Excellent. Okay. So as I say, there are just 3 cases here. It's not too complex. There are no tricks. I'm not trying to trick anyone. So have a look at this cornea, and I appreciate that there are a lot of indices on the Pentacam. We can look at, as we say, decentration indices. If we have a wave, we can look at stromal thickness and things like that. But not everyone has those machines. And if you were just looking at this topography, would you do LASIK on the patient? So I've essentially specifically excluded the indices. But if you have a look there, it's not particularly decentered, the apex of the cornea. It's nice and thick, 556. It's not particularly steep. Posterior elevations are pretty good, not perfect, but most patients would happily perform LASIK on that cornea, especially if it wasn't a high myope. So does anyone, I get that there are more things we can look at, but in your mind, would you look at that and say, no, they can't have LASIK? Obviously, or LASIK or SMILE, depending on their refraction. So then next, if we go to the next slide. This patient's combined their topographic and biomechanical report. So we've got one of these. This would be a case 2, would it not? This is a case 2. So we have a patient with good topography and a slightly borderline corneal biomechanic index, and a TBI that's about 0.43. It's not ideal. Now I've learned something. I would look at my SPA1, which is low, 84.6. So in that case, looking at that, we would not do LASIK or SMILE on this. But if the SPA1 was over 100, it might be reasonable to do something like SMILE Extra or potentially a PRK. LASIK and SMILE give better vision than a PRK. LASIK, if it's topography guided, better again. So they're always nicer procedures. As we said, you could say, oh, can't you just do a PRK? Well, it's not very nice. Patients don't like it. They need to take a week off work. So it's just a classic example. And the other thing is our biomechanic IOP in this case is normal, 14.7. So it's just an example of how biomechanics can... Well, this is one where biomechanics would potentially rule them out. But as I say, biomechanics does not detract from your practice. You do not rule out many patients at all for refractive surgery. You might modify what you do. Patients like the fact they're having extra screening. It helps them understand what they're having done. They have no idea what topography is when you try and explain it to them. They can't even fathom tomography, but they get that I'm looking whether or not your cornea is strong or weak. And it's the bad patients, it's the unhappy patients who are the worst bad advertising for you can possibly have. So next. Okay, as I say, no trick questions here. You just got to look at this display and is this patient progressing and do they have keratoconus? So again, I haven't actually tried to trick anyone, but everyone just puts up abnormal slides all the time, and this one is not abnormal. This patient is not progressing. So the anterior radius of curvature is well within the normal range. Remember, green is good. So they are not within the population of keratoconus at 80%. No change whatsoever in their posterior radius of curvature. And even though their central corneal thickness starts creeping into the range that could be keratoconus, it's also still perfectly within the range that the normal population can have. This is not a patient who is progressing with keratoconus. They don't even have keratoconus. It's just to show a nice normal slide occasionally so that you, instead of seeing abnormal ones all day, you can see one that's perfectly normal. I think I have one more. Next. Okay. So have a look at this patient again. Would you do LASIK on them? I appreciate we don't have all the topography up there, but the bad D is good. The bad D is very good in this case, but the biomechanics are bad. So biomechanic index is 0.74. These cases are rarer, right? They're not super common, but these are the ones you're ruling out because they're hard to make happy in the end. If they come back with post-LASIK ectasia, you have to see them a lot of times, you have to do a lot of treatment, you have to get them happy. 0.66 for our TBI. So remember TBI about 0.26 and less for LASIK, just on a basic assessment. So let's have a look. Remember the SPA1 is less than 100, so bad. This is a type 2. We've got a type 2 with a low SPA1. We don't want to touch this patient with LASIK or Smile Extra or anything like that. And low biomechanic IOP, you can see there the IOP and the normal IOP and the biomechanic don't differ too much. So this is a patient you are going to leave alone. This is a patient who's better to have an implantable Collamer lens than to have a corneal-based laser surgery procedure. So again, just documenting the advantage of topography. Topography is fantastic, but biomechanics can certainly add to it in your clinic. It's my last one.
Thank you, Dr. Brandon Konin. Sekarang kita sampai pada, mau dilanjutkan? Silakan. Please, Dr. Gairi Kundu.
So we have something very special that we want to introduce to you. So we have a new Pentacam that is coming, right? And so we have the fortunate to have Dr. Garrick, who's had the ability to work with this new Pentacam with Professor Rohit and his team. So they're going to be able to show you some of the images and details about this new Pentacam OCT. So we've taken an OCT and a Pentacam and brought them together. An anterior segment, no, or just a corneal OCT plus shine fluke for your anterior segment, right? So the best of both worlds, and Garrick's going to give us a little bit of more detail.
Thanks, Richard. So number 4. Yeah, so I had a fortune of working at the Pentacam OCT. The devices are launched, they come, and we are really lucky to work on these devices early. So just a quick glimpse on what our work on Pentacam OCT. So I spoke about the fact that you're looking at images, you're looking at devices which can do multiple functionalities, right? And once they integrate and add on to certain functionalities, it shouldn't compromise on their core competence, okay? You have a Pentacam, you're adding on to something else. It shouldn't say that, I will reduce my sensitivity of ectasia detection and indices, but I will focus more on OCT. So I think that's what Oculus has done well, is where though they have, the Pentacam HR, the Pentacam AXL, the Pentacam AXL Wave, and now the Pentacam OCT, their core functionalities still remain the same. In fact, I've taken it a notch higher. So, you're of course looking at topography and biomechanics. I spoke about cases where epithelium plays an important role. I spoke about cases where you would, of course, require an OCT to add on to your armamentarium as, in a practice where you're doing cornea and refractive. So that's something which is important in these cases. So I'll be, we've looked at the role of epithelium. So what I've kind of segregated is what all it can help me in. Can it help me in looking at the epithelium? Can it help me looking at Bowman's? What about the stromal layer? What about the Dua's layer? Does OCT have an important role in this? This is not something which you can do regularly, not with a single device as of yet, where you're looking at your, of course, your cataract and refractive surgery indices which are intact, but you're adding on to an OCT. So this is basically an ultra high resolution OCT. Of course, everybody knows about how it plays an important role, but we'll kind of, dwell a little deeper into how it helps us in our clinical practice. Patients coming in for screening for refractive surgery, what do we do? So I've spoken about this in the first talk. You see your, patient coming in with your opinion for refractive surgery. You see that many of the parameters, the dry eye parameters are normal, OSDI is slightly on the higher side. Again, you see that area where there is, you see that focal inferior steepening in the left eye. And this is where we kind of have published on how epithelial mapping in refractive surgery is sometimes very important. And if you see that area where there was a focal inferior steepening, in fact, it was the epithelium which was kind of masquerading. So many of the devices nowadays, any topographer, any tomographer, is built for, under the assumption that the epithelium is regular, okay, and it's uniform, which is actually not the case. Okay, so what invariably happens is in scenarios where there are focal epithelial changes, it can get masked. So you should be aware of that once, of course, but if you're not aware of that, adding on to an epithelial thickness or an OCT plays an important role. So, therefore, what we've also kind of correlated is epithelial changes invariably correlate with subclinical inflammation, and that is something which we have found in your, your confocal microscopy, which I've shown. And what is important to know is if you're operating on an already inflamed ocular surface where you see already epithelial changes, it does lead to post-operative outcomes which are not as you expect. Okay, so a healthy ocular surface and an epithelium which is a marker to tell us about a healthy ocular surface is very important in preoperative screening as well, so that your outcomes can be optimized even more. You have, of course, your topography, your biomechanics, your ectasia detection screening modalities, but understanding that epithelium can be a surrogate marker, and using a Pentacam OCT, we could screen that preoperatively as well. This is again another, where this is a patient with a normal, you see the CBI, TBI normal, the left eye, CBI is somewhere in between, TBI is somewhere in between. But what are we missing? It's borderline in the left eye, but there's normal biomechanics in SPA1. What do we do in such scenarios? So this is where, epithelium thinning, if you see in the left eye, there's a focal area where it is thin. Not a very significant change, but what we've kind of correlated, Dan Renzi spoke about in cases of keratoconus where there is thinning over the area of ectasia surrounded by a compensatory hypertrophy around something like a donut sign. This is not a donut sign, no doubt, but you see an area where there is some amount of focal change in the epithelium, and that could be driving, case scenarios here. Again, the crux of the matter is epithelium changes, look for ocular surface issues, treat the dry eye. In fact, sometimes adding on to additional dry eye options before you actually go in for refractive surgery can play an important role. So Pentacam OCT is a very high resolution device. If you see that, compare it to some of the existing devices, you know how good it is. I'll come to it a little later regarding our recent work we've done on the tear film. But a high axial resolution, and that is what something matters. It has you look at a 9mm scan, high resolution, and of course, preserving the modalities of what a pentacam originally was supposed to do, and that is what is important. Now, I spoke about epithelium. Can we do something beyond it? Yes. Okay. This is how you're looking at some Bowman's. Because it's a high resolution device, if you see, we in fact are able to image very, very fine Bowman's microdistortions. And post-operative patients coming back with some amount of glare, halos, this could be a very useful tool. We have come about with something known as a Bowman's roughness index. So we did this quite some time back, where we looked at those micro distortions. It's basically a summation of the positive and the negative distortions. And what we found is that that correlated kind of, if everything else is normal, that kind of correlated well with their scatter, which we see on the optical quality. There are some tools which calculate that. So micro distortions and post-operative unhappy patients can be an important cause. So therefore, it's important that we image that, and a higher resolution OCT, such a pentacam OCT, does that. So I don't want to go into the details on how a lenticule procedure can contribute to it. What we have shown is when you're comparing a biconvex with a planar convex, that itself plays an important role in which one has a higher propensity. But anyway, to sum it up, you're looking at the Bowman's roughness index or Bowman's microdistortions. You need a high resolution OCT, and the pentacam OCT gives you. And of course, as cornea surgeons, we love our preoperative planning. How do we look at scars, the depth of scar assessment, and you've shown it across varying spectrums. That you can, of course, the cornea profiling of the OCT is superb. Intraop lenticule profile, if you can see, this is a part of a study where we have actually, once the lenticule is made before it's removed, you can actually see the shape of the lenticule, and that is again an important way. How different refractive surgeries, you see the lenticule profile, and this is done on a pentacam OCT. Now, the next aspect is on some novel structures. Ideally a conventional OCT is imaging perpendicular, is imaging only in one direction. But ideally it should be imaging perpendicular at every point, and that is what increases your contrast, and that is what increases the resolution, and that is why this is a little different, and this has a higher resolution and a larger field of imaging. Post refractive surgery, we were actually able to see even image up to the level of Dua's layer. So that is something which we have shared data. This is again part of our ongoing work in pentacam OCT, where we are utilizing it for varying, not only for OCT applications like scar, not only for epithelium. We've also shown it to image Bowman's. We've also shown it to image post-operative patients in the Dua's layer as well. So the next aspect is what we've also correlated it is the distribution of the ultrastructure. Now, a higher resolution image of the OCT, there is a concept known as speckle intensity. Okay, that is something which you cannot get in many of the OCTs simply because of the resolution. You see the distribution of those fine points in the OCT, and that actually correlates with the strength of the cornea and the strength of the stroma. And what we were able to do with this is correlate that ultra high resolution image, look at the speckle intensity, and correlate that in patients with keratoconus, and that was a very good correlation. So you were looking at a high resolution image, you're looking at fine individual speckles which we were able to detect because of high axial resolution, and that is also giving me an indirect indicator of whether it's a strong cornea or whether it's a weak cornea, and that is something which is a very useful tool. So I quickly go through some. They've also imaged it on a series of patients. Post cornea. I'm also a cornea surgeon. Scars, post transplants. Preoperative, post-operative DALG, DSEX, dystrophy patients. Syndromes, you get a very good anterior segment image as well, post-intacs, post-DALC. And what is interesting, before I end off on our work on pentacam OCT, is because it gives you a very high resolution, and it also can image the tear film. Okay? And the tear film is very, very important. Why? Because it's also a medium which can, affect aberrations, whether it is pre or post. And imaging the tear film can also throw light. So we are not only going into epithelium first, imaging the tear film plays an important role. If you see what we're able to do with the Pentacam OCT and the cross section is now it's very, very early work, something which Dr. Rohit shared with Richard recently, is on how we are able to reconstruct subtle abnormalities of the corneal surface from the tear film which was detected on the Pentacam OCT. So it's like a topography of the tear film, and that is possible only because of how high resolution imaging this is. So this is still work in progress. This is a KC, and this is something which is exciting and moving forward. This was recently something which the team did, Dr. Rohit, our imaging team, and this was shared with Richard. So it's a new dimension of corneal assessment, a tool which is time plug and OCT, and it is not compromising on either of the functionalities. High resolution, you're imaging the Bowmans, you can sometimes image the duas. Of course, you're having applications of epithelium, and now we are showing that tear film imaging is also something which is possible. So it gives you a valuable insight into many of the other aspects which we have not dealt with when I spoke about topography and biomechanics. So a new launch for Oculus, and it's a fantastic tool. Thank you.
Thank you, Dr. Kundu. Sekarang kita memasuki sesi diskusi. Kami persilakan kepada para panelis, Dr. Uco, Dr. Dini, dan Dr. Emi untuk naik ke depan, naik ke panggung. Para peserta, jika ada yang ingin ditanyakan, didiskusikan, atau mungkin ingin sharing pengalaman, kami persilakan. Silakan, Dr. Rucita.
Okay, good morning to all the speakers. It's a very interesting topic that you have there. So now we have all the modalities to screening for keratoconus or to manage the treatment for the patient. I have this particular patient. She suffered from Bell's palsy. She is in a recovery for Bell's palsy. She have normal blinking rate on the right eye and abnormal blinking rate in the left eye with reduced blinking rate. So obviously from the epithelial thickness, we see there is some kind of thickened epithelial in the left eye due to the reduced blinking rate, while from the topography, from the pentacam, I see the elevation, back elevation, slightly back elevation on the right eye. And in the left eye, there is a prominent back elevation and a slightly anterior elevation. From this case, I want you to know if you have this kind of patient in your clinic, what would be the best approach to managing such case? And then could the abnormal blink pattern and possible exposure-related ocular surface change affect the accuracy or reliability of anterior segment imaging such as pentacam, or maybe affect the measurement of corpus? And is there any precaution if we going to interpreting the data from such patients? Thank you for your insight.
So, so I spoke about your ocular surface issues playing a role in how it can alter your curvature maps.
Yes.
I spoke about, so you have bells, you have changes on the ocular surface that invariably will cause changes in the epithelium that could mask changes in your curvature, right? So what would be an important aspect is, of course, you're treating the ocular surface simultaneously as you're imaging. But what could be a better option is when you're interpreting the patient as he or she comes, is doing multiple scans, okay? Ideally, we normally recommend to do 2 or 3 scans, the concept of repeatability. But you do 4 or 5 scans and take the best 2 or 3 out of them for interpretation. But again, you are already aware of the fact that the patient has bells, will have changes in the epithelium, and that of course will cause changes in your pentacam or that. So that is something you're already aware of, and you're already mentally ready with that. In terms of how dry eye affects devices, you're right, it does. We have also shown that the concept of tear optics. There's a device called OCAS, Optical Quality Analysis System, which kind of gives you scatter at the tear film interface, and that has affected all devices. But what we have shown is repeatability is still the best in Pentacam in spite of alterations of tear film optics. So if I have a patient who has a dry eye or who has changes in the ocular surface as a consequence of epithelial remodeling, I would still rather do it on a Pentacam, which would still give me as close as an accurate measurement as it would. So does that kind of answer your question?
Yes, but of course this patient is not a good candidate for laser refractive surgery due to the reduced blinking rate. And what about the Corvis interpretation? Would be any change if there is such?
Corvis interpretation in tear optics, not something we have studied. We have seen that dry eye and altered tear optics affects all device measurements, right? It's not about the accuracy of the measurements. Therefore, you should ideally take serial measurements to be just sure that the value which you're looking at is actually the real value. Say, for example, you just measure and you look at, say, just the CBI. It would be prudent to know that the CBI is 0.2, 0.25 across an average of 3 or 4 scans. That would be the best way to negate the effect of ocular surface or dry eye on machines. But there is some effect. You cannot say that there cannot be an effect. But having said that the effect being there, devices are coming up with how, in spite of that, they still tend to be repeatable. So you are already aware of it, so you know how to interpret it. Is as simple as that. Yeah.
Okay, thank you very much.
Mungkin ada tambahan dari para panelis? Tidak ada? Baik. Silakan, Dr. Jenny.
Mungkin saya sedikit bukan nambah ya. Seperti kata Dr. Garik tadi bahwa kita harus treat dulu ocular surface-nya. Diharapkan itu baik, baru kita bisa interpretasi dengan baik korneanya, termasuk biomekaniknya.
Iya, dan mungkin sedikit lagi, kita juga sebenarnya ada aspek yang sederhana yang bisa kita perhatikan pada pasien-pasien dengan yang tadi kelainan blink reflex atau ocular surface abnormality seperti halnya simple dry eye seperti itu. Sebenarnya kita satu hal yang bisa kita lihat, stabilitas refraksi aja. Jadi kita ketika bertemu dengan pasien-pasien dengan kedatangan pertama, dia visus sebetulnya tidak baik, kemudian refraktif errornya juga tidak begitu besar, tetapi BCVA-nya tidak bisa 1,0, kita udah curiga. Kita biasanya curiga apakah memang ada ocular disease, surface disease atau apa. Nanti kita treatment dulu, cek lagi kontrol, dicek lagi. Biasanya ketika kita treatment dry eye misalnya, itu impact-nya sangat besar. Bahkan saya punya pasien yang BCVA uncorrected distant visual acuity-nya 0,3. BCVA hanya sampai 0,6, 0,7. Ketika dilakukan treatment dry eye 1 sampai dengan 2 bulan, dia bisa BCVA tuh ternyata 1,0 dan visus dasar 0,8. Jadi sebegitu besarnya dampak kelainan ocular surface ini kepada kondisi refraktif seseorang. Jadi kita jangan sampai memaksakan suatu tindakan corneal refractive surgery pada pasien-pasien dry eye karena kita bisa ketipu. Tadinya ternyata nggak ada minus, nggak ada silindernya seperti itu. Mungkin itu tambahan sedikit dari saya. Terima kasih.
Terima kasih Dr. Emi. Biasanya berapa lama waktu yang dibutuhkan memperbaiki ocular surface sampai ada perbaikan visual acuity?
Oke, bervariasi ya. Biasanya kita kalau treatment dry eye itu biasanya kan pre-assessment dulu. Dari situ nanti kita bisa melihat perubahannya. Biasa di atas 1 bulan baru kelihatan perubahan yang terjadi pada ocular surface atau kondisi refraksinya. Atau mungkin kalau kita biasanya kerjakan, kalau di saya punya pakai hidra gitu, ada perbaikan di situ dan juga sign yang mungkin pasien itu kadang-kadang nggak begitu merasakan juga, apalagi kalau anak muda. Itu kadang-kadang mereka tuh dry eye tapi tidak merasa dry eye gitu. Jadi itu ada di refraksinya tapi yang kelihatan. 1 bulan. Tapi saya biasanya bilang sama pasien 1 bulan sampai 3 bulan loh kita lihat. Gitu kalau nggak buru-buru. Ya.
Baik, terima kasih Dr. Emi. Ada tambahan Dr. Ucu?
Terima kasih. Terkait pasien tadi Dr. Ucita, sebenarnya kalau kita udah dapat pasien seperti itu, dari awal aku udah nggak memikirkan refractive surgery ya, apalagi laser vision correction, apalagi nanti terkait dengan outcome yang mungkin timbul. Pemeriksaan dari pentacam, terus sejenis topografi, corvis, dan lain-lain itu, bagi saya sih untuk pasien dry eye yang udah kelihatan dry eye-nya di slit lamp, terus kita fluoresen, kita terus kita LVC juga butuh akurasi, butuh kedepannya dry eye-nya bisa timbul fase LVC, mungkin bisa jadi bahan pertimbangan kalau kita nggak push ke arah LVC gitu loh. Jadi kita treat dry eye-nya. Nah terkait dry eye-nya ini treatment dry eye itu kan terkait kausalnya ya. Kita udah treatment nih pasien nih datang ke teman sejawat ya. Sebulan kita treat mau lasik nggak bagus-bagus dry eye-nya nih. Ternyata dia defisiensi vitamin D, kasih vitamin D sama artificial tears saja biasa, 2 minggu juga udah bisa kita lasik tuh. Nah kadang-kadang kita harus lihat lebih luas lah, apa sih kausalnya nih dry eye nih si pasien, apakah ada faktor alergiknya, ada faktor autoimunnya, ada faktor macam-macam. Yang sering miss itu ya defisiensi vitamin D. Setelah kita kasih vitamin D sekian ribu, terus kita ulang pengukurannya memang naik dan keluhannya berkurang, ocular surface-nya bagus, dan akhirnya dia bisa LVC. Nah, jadi kausal dari apa sih penyebab dry eye-nya ini harus kita pertimbangkan ya. Selain pemeriksaan dasar ya pakai fluoresen, di slit lamp kita lihat tibatnya dan lain-lain macam-macam, itu kan sangat murah untuk pasien. Terima kasih.
Terima kasih Dokter Uco. Apakah masih ada pertanyaan dari peserta? Silakan Dok, mungkin terakhir ya karena waktunya terbatas.
Terima kasih dokter. Sebetulnya saya mungkin mau menanyakan, ada satu kasus yang baru saja kami dapatkan di rumah sakit kami. Jadi sebenarnya kasusnya pasien wanita usia 30 tahun datang ke kami, sebetulnya keluhannya post trauma di satu matanya, jadi di mata kirinya. Nah, tapi ketika dilakukan pemeriksaan memang pasien ini ada riwayat lasik sekitar 4 tahun yang lalu di klinik yang berbeda. Nah, pada saat kedatangan mata kanannya uncorrectednya 10/10, sedangkan mata kirinya 2/60 dengan koreksi spheris min 8 jadi 1/2/10. Dari autorefnya spherisnya min 8,5, silinder min 12. Kemudian kami lakukan OCT kornea, dapatkan penipisan, jadi pada mata kanannya ketebalan sekitar 428, mata kirinya 357. Kemudian kami lakukan pemeriksaan dengan pentacam, mata kanannya normal saja, tapi di mata kirinya K1, K2-nya itu 43 dan 51, Kmax-nya 47,3. Mungkin ada masukan atau tanggapan dokter untuk tata laksana pasien seperti ini. Jadi pasien minggu yang lalu kami cross linking. Nah, tapi untuk tata laksana selanjutnya mungkin ada masukan dok untuk kasus seperti ini. Terima kasih dok.
Terima kasih dokter. Dari para panelis, silakan.
Terima kasih. Sebenarnya ini kasus bersama dari tim KPR kami di Undaan. Jadi untuk kasus ini itu kita harus pastikan dulu diagnosanya, apakah ini betul karena trauma atau karena ektasia. Untuk kasus ini kita lakukan OCT, kita cek epitel map-nya. Dari OCT dan gambaran pentacam-nya kami tegakkan diagnosa ini ektasia gitu. Jadi mungkin yang perlu kita minta pendapat from Dr. Cronin and Dr. Gairik Kundo, yeah, this case is about ectasia post-LASIK, but the patient said that they had trauma. So how to diagnose this is Yes, ectasia or caused by trauma. Is it epithelial map have a role because we don't have Corvis in our clinic? Thank you.
Okay. Might be one more for you. I mean, if you don't, I'd say, oh, that's easy. I'd do a Corvus and give you the answer. I guess that's why we have some of these machines. What was the trauma again? What was the injury?
A kick on the face. But we are not sure about the mode of injury itself.
Yeah. I mean,
I don't know if that would cause.
yeah, I'd say it's ectasia.
So I don't know if
Yeah.
that would be an inciting factor for ectasia. A sudden one single injury might not be the cause for your post-operative ectasia. So serial follow-ups with your biomechanics, the CBI, LVC, is something which you should ideally do. But if you feel that trauma was an inciting factor, I don't know, it could be incidental that the patient has come with ectasia, has had an injury.
We're not sure about the trauma
Yeah,
itself.
so some patients tend to relate their post-operative weakening to your injury, but I don't think that is the case. Everything else you've spoken about, your pre-operative factors leading to your screening the patients right, and also following in the post-operative biomechanics, that should still hold the key. If you don't have Corvus and if you have only a Pentacam, you can still, of course, follow them up. Important to look at your post-operative ablation, whether it's centered, decentered. Invariably, post-thoracic ectasias would be an inferior steepening, which then would gradually progress to an ectasia. So keeping them apart. So many of the parameters, if you're looking at post-operative, post-LASIK Pentacam parameters might not hold true. So your D values, that all of course changes after your refractive surgery. But your 4 maps and serially following them up could be a screening way of looking at it. And of course your clinical evaluation and your refraction. So you see a cylinder developing, you see there is some amount of inferior steepening irregularity, and you follow them up after maybe a couple of months and you see that has increased. That could be an ectasia and evolution in spite of not having a Corvus with you. And of course look at risk factors. Eye-rubbing is still a risk factor for post-operative ectasias in progression. You're also looking at in females risk factors such as pregnancy accelerating the changes which is post-LASIK. So I think you need to kind of play around with your Pentacam, your 4 maps, serially following them up. But of course, we looked at how Corvus helps, so that is also something which is useful.
Mau nambahin ya, Dokter Tigor ya, tapi bahasa Indonesia ya dok. Jadi gini, traumanya itu kan nggak tahu nih riwayatnya kita nih ya. Kita melihat pakai 2 mata Dokter Tigor. Dia udah ngalami 4 tahun lalu LASIK. Bagus kata dokternya, bagus kan. Dia nggak datang kontrol lagi nih ke dokternya. Ini progres ektasianya pelan-pelan tanpa dia sadar. Sampai satu titik awareness-nya dengan binokularnya responsif dari sisi yang mengalami ektasia itu terhadap benturan terhadap apapun lah yang mengarah dari sisi sebelah sini yang udah mulai turun, akhirnya kurang. Tapi kalau trauma itu menyebabkan ektasia sih nggak akan pernah. Nah, biasanya kejadian ektasia pasca post-LASIK ini 2 tahun, 4 tahun. Dan beberapa pasien ektasia post-LASIK ini yang kutreat, biasanya setelah 4 tahun, dan bisusnya 1-0. 1-0, tahu-tahu 4 tahun turun jadi 0,8, yang datang ke saya 0,3, 0,4. Tapi setelah di crosslink, dia bisa 0,8 lagi, urologis. Tapi memang kalau kita kena ektasia pasiennya, kita khawatir. Nah itulah gunanya Corvis ST itu biomechanical itu yang punya sensitivity dan specificity biomekanik membantu kita untuk mencegah 1 dari sekian ribu kasus. Yang dulu katanya 1 dari 5.000 kasus adanya ektasia yang walaupun topografinya normal, tapi sekarang ini di literatur terakhir 1 dari 300 kasus, satunya itu bisa jadi masalah untuk kita kalau misalnya kita nggak tahu biomekaniknya, walaupun topografinya normal ya awal pre-op-nya. Di crosslink akan sangat membantu. Mau thickness berapapun itu sekarang udah ada ilmunya lagi. Dan visus biasanya naik lagi. Dan pada pasien urologis itu udah 0,8 lagi. Semuanya happy, dokter yang mengerjakannya juga happy, pasiennya juga bisa kerja lagi. Itu aja dokter Tigor ya, makasih.
Terima kasih dok.
Baik, terima kasih. Dengan demikian kita akhiri sesi 2. Thank you for the speaker for your very valuable presentation. Saya kembalikan lagi kepada MC. Terima kasih.
Terima kasih dokter ya, boleh kita berikan tepuk tangan, luar biasa sekali, masih semangat para dokter sekalian. Wah, senyumnya manis sekali dokter yang di sebelah sini ya. Baik, untuk panelis dan juga moderator bisa stay dulu dok, karena kita mau foto bersama. Baik, sebelum kita menikmati hidangan makan siang yang sudah disiapkan, mohon izin untuk boleh mengundang seluruh para dokter yang sudah hadir untuk bisa maju ke depan. Kita akan berfoto bersama ya. Jadi all the speakers boleh di atas panggung. Ya, nanti kita akan ada yang di atas dan ada yang di bawah. Kita atur dulu. Sekali lagi jangan lupa nanti malam kita akan ada dinner bertempat di 360 Restaurant ya. Yang pasti selain nanti kita bisa santai-santai, yang hobi nyanyi tadi siapa ya dokter ya? Oh bukan dokter, kirain dokter loh. Duet mungkin nanti sama dokter ya. Baik, kita tata dulu. Nanti dengan dokter siapa saya kalau boleh tahu? Dokter Joni. Oke, sepertinya dokter Joni. Bukan, saya dikerjain sama dokter ya. Oh, gak apa-apa wes. Nanti aja saya penasaran sama namanya. Karena saya dikerjain, nanti bawain lagunya 2 album ya dokter. Dan tentunya nanti selain ada juga bisa nyanyi bersama dengan dokter yang mengaku dokter Joni. Nanti akan ada door prize juga. Jadi para dokter sekalian, ini door prize-nya luar biasa sekali. Jadi pastikan nanti malam Anda hadir ya di 360 Restaurant, itu ada di lantai 23. Baik, tempatnya sudah siap sepertinya. Boleh saya undang untuk para dokter boleh maju ke depan. Kita akan mengabadikan momen spesial ini sebelum sama-sama menikmati hidangan makan siang yang tentunya sudah disiapkan di area pre-function atau di area luar ballroom. Sekali lagi mohon izin untuk seluruh dokter yang hadir beserta tamu undangan, para narasumber, panelis dan juga moderator untuk bersama-sama kita mengabadikan momen spesial pada siang hari ini. Sekali lagi untuk seluruh peserta yang sudah hadir di ballroom, dengan hormat boleh dibantu untuk maju ke depan. Silahkan dokter. Oke, kalau di bawah ini dirasa tidak cukup, boleh naik ke atas ya dokter. Boleh bersama speakers kita dan juga panelis. Silahkan. Dan juga sekali lagi mengingatkan untuk sistem LMS Symposium dan juga workshop ini dibuka sampai pukul 12 malam. Boleh naik ke atas panggung ya dokter ya. Kalau sudah merasa penuh di bawah boleh naik ke atas panggung. Di atas masih ada beberapa spot yang tersedia. Oke. Yang sebelah kanan belum keisi atau diambil kursinya? Ini ada satu lagi nih. Ibu dokter silahkan boleh ditempati. Paling depan loh, enak loh. Nanti di posting di Instagram terkenalnya lebih cepat lagi. Silahkan boleh. Oh, ada 2 spot. Ada 2 kursi lagi. Silakan dok. Yang di samping kanan dan kiri gimana? Oke, agak merapat. Bapak Ibu dokter dimohon untuk bisa merapat ke tengah. Silahkan. Agak mepet sedikit lagi yang di atas. Boleh. Oke, yang di sebelah kanan boleh naik ya. Kita sediakan beberapa kursi di atas panggung. Biar tidak berat sebelah. Oke.
Dokter, permisi.
Yang di bawah
sini
sudah cukup?
Dapat ya. Ke atas aja dok, karena udah nggak dapet soalnya.
Oke, apakah sudah in frame semua belum ya? Oke.
Ini dapat nggak yang di sini?
Boleh naik yang sebelah
naik
kanan. Gimana?
Ini dapat nggak ya?
Ya. Boleh kursinya ditaruh di atas panggung supaya bisa 2 saf untuk yang di atas panggung. Ya karena ini masih bocor ya, belum in frame semuanya ya. Boleh dibantu mas, di atas panggung dikasih kursi supaya bisa jadi 2 saf ya, begitu ya? Oke. Oke, silahkan boleh dibantu. Mundur dikit ya, kita akan tarik sedikit. Oke, sambil nunggu fotonya kita mulai, mungkin ekspresinya boleh dilatih dari sekarang dokter. Nanti kita mau ambilnya 2 kali foto ya. Yang pertama serius. Kalau dokter serius gimana? Nanti yang kedua kita boleh gaya bebas. Nah setelah foto 2 kali, nanti kita akan juga ambil video sama seperti foto. Yang pertama gaya serius, tapi seriusnya sambil waving ya, sambil dada-dada. Yang video kedua boleh dibebaskan gayanya. Oke. Aman? Yang di sebelah kiri boleh merapat sedikit lagi. Oke, boleh dibantu merapat sedikit lagi.
Bapak ini di belakang, ibu geser.
Oke. Ada boleh, silahkan kita coba ya. Ibu dokter boleh duduk di sini, Ibu dokter. Boleh, silahkan. Silahkan. Tidak dipungut biaya ini, Bu. Silahkan dok, silahkan. Ayo, silahkan dokter. Maunya berdiri ya. Ayo silakan dokter supaya bisa segera menikmati makan siang. Iya, yang di sebelah sini harus ke sini soalnya dokter ya. Dimohon kerjasamanya, oke? Satu lagi dokter. Baik, terima kasih. Oke, sudah. Oke. Ya, kayak Pak Nino tuh. Oke. Baik, siap. Saya hitung ya. Ini gaya serius dulu ya, dokter ya. 3, 2, 1. Oke, sekali lagi. 3, 2, 1. Alright. Dicek dulu ya. Bagaimana, aman? Sekarang boleh disiapkan ekspresi gaya bebasnya. Oh, sekali lagi masih gaya serius dokter. Oke, 3, 2, 1. Tahan. Oke, gaya bebas sekarang. 3, 2, 1, bebas. Satu lagi. 3, 2, 1, bebas. Satu lagi. 3, 2, 1, bebas. Oke, tahan. Aman? Sekali lagi gaya bebasnya dokter, bebaskan ekspresinya. 3, 2, 1. Lagi? Aman? Oke, kita bikin video ya dokter ya. Oke. Wave your hands to the camera. Sudah? In 3, 2, 1. Lagi? Oke, sudah? Alright, Venus, thank you so much. Luar biasa, silahkan kami persilakan Anda untuk bisa menikmati hidangan makan siang. Para dokter sekalian ada di area pre-function atau di luar ballroom, dan sekali lagi untuk sistem LMS untuk simposium dan juga workshop akan dibuka sampai pukul 12 malam. Dan jangan lupa untuk gala dinner tentunya selain hidangan makan malam yang spesial yang sudah dipilih dan disiapkan untuk bisa Anda nikmati, juga banyak hadiah yang spesial juga yang siap untuk Anda bawa pulang. Jadi pastikan setiap rangkaian acara sepanjang hari ini tidak ada absensinya sama sekali ya para dokter sekalian. Silahkan kami persilakan Anda untuk bisa menikmati hidangan makan siang di area pre-function. Please enjoy.